Oh, I don't know as many.
Is I'm going to turn this over to Kay Norris right now for a couple of special presentations.
We are wanting to honor two people who have really seriously contributed to the development of the Montana Pain and Symptom Management Task Force, which is now developed into the Montana Pain Initiative. And without their help, we would have really been struggling. The first person I'd like to honor is Carolyn Squires, Senator Carolyn Squires, who I actually used to get to vote for. Before I moved. Carolyn is, as Dr. Seekers told you earlier today, Carolyn is the senator that put the Senate Resolution 28 through, which established or recognized the development of the Montana Pain and Symptom Management Task Force, and she has been a steadfast supporter of the Montana Pain Initiative from the get-go. And unfortunately, she's turned out and leaving. And I used to get to vote for her because I lived in her district, but then I moved. And so anyway, I would like to introduce to you Senator Carolyn Squires, and she would like to say a word, and here is your award. Thank you.
For the session because, but I just want to thank you, and I just want to share something with you. I'm an LPN, and I nursed for 32 years at Missoula Community Hospital, and I started in 1967, and I saw the various levels of taking care of patients, and I was on the med surg floor most of the time, so I was fortunate and unfortunate at times to be with those who were in the process of dying. And to see the advancement that's come across our path and our ways now is wonderful in comparison to what it was when Granny could only have ibuprofen. And that was way too much. So I want to thank you very, very much for everything that you do in making this much easier for people in their suffering, whether it be through death, surgery, any type of activity that would necessitate pain. Because without you folks prescribing the drugs, taking care of the patients, and understanding and being able to articulate that they're not drug addicts, drug seekers. I've been in an emergency room too. Had to go look at the box because he had a toothache. And by God, he'd been here 3 times. Didn't make any difference. He couldn't afford to go to the dentist or get the teeth fixed. But he was a drug seeker. So I promised I wouldn't say much, but I just want to say thank you. I fully understand. I need more education. And I can't thank Kristen, and I can't thank the American Cancer Society folks anymore because they're wonderful people to work with. So thank you, and please keep up the good work.
And so the second award is our Volunteer Leader Award, and that goes to Dr. Catherine Borgenecht, because she was seriously at beck and call. She even gave me her cell phone number. And anytime I need her, she is there. She has been on every single committee that we have had from the beginning of the Montana Pain and Symptom Management Task Force, and she's the medical director of the executive committee for the advisory council of the TBI, and I can't imagine doing this work without her. Catherine, thank you very much. And I'm just going to give you a little inside information to 2, we nominated her to be a volunteer champion. I can't remember exactly what it's called, but with the Alliance of State Pain Initiatives, which is the national organization that oversees us, and she got it. So she gets to go to the conference in October, and she gets to get this award. So we are like, I'm so jacked. And there's a lot of states in the Alliance of State Pain Initiatives, and our own Dr. Morgan is the champion.
Well, I'm talking about.
Actually, I'm filling in for someone else this evening, David Woodmansey, who I don't know, but he's a senior field representative from the American Cancer Society. He was actually going to host this panel this afternoon, but he is caught in the hurricane season. So our hopes go out that he is not in the hurricane, just in the hurricane season or in the hurricane. So anyway, I'm going to kick this panel off. This panel is really about access and questions about access to effective pain management. And what we thought we would begin to do is start a dialogue about some of the barriers to effective pain management and how we can begin to work to overcome some of those barriers. So tonight I think you're going to hear from a host of different perspectives on the issue of pain management and what it means in various different scenarios throughout the healthcare system. So first I'm going to introduce Lois Fitzpatrick.
Yep.
Lois, we thought we would kick the panel off by the perspective of a pain patient. So what's it like for a person who is dealing with the system, dealing with this disease process, and what's the good things and what's the bad things? So I'm hoping you're going to set the stage and sort of give us some idea of what we should be discussing the rest of the evening. Okay? Thank you.
Thank you, and we call that no pressure. When I told my husband I was going to speak as a pain patient here, he said, "Good, tell them how much pain you give me all the time." So I figured I would. Actually, to be honest with you, preparing for this did put me into a great deal of pain because I am so used to, just stomping the pain down and not thinking about it until someone asks me. But when Kristen asked me to share my story and other stories I had heard, I had to open those floodgates up again. And I'll be glad tonight when my part is over because I can clamp them back down and feel a little better. But here I am. And I'll tell you a bit about my story. I'll tell you about some other people that I know who have been in pain and that have had good experiences and bad experiences. In 1986, I was diagnosed with fibromyalgia. And that was very difficult for me because I was only 34 years old. I had just had a baby 14 months prior. We were moving into a brand new house that was much larger because we were in the process of adopting a family unit. I was at my job that I love and adore and still do. And as we moved into the house, about 2 weeks after we moved in, I could not move, I could not breathe. I was in agony. I couldn't believe what my body was going through. I was very fortunate. I was able to see my doctor immediately that day. And I went into my family physician, who was Dr. Tom Norris at the Hawkins Lindstrom Clinic in Helena at that time. And he looked at me and said, "Oh my God, you're in pain." Wow, that made me feel so much better because someone had actually recognized. Now, of course, it was very easy to tell because I'm walking like this. I can't stand up. And so Tom gave me some pain medication, and we talked about what it could be, and he thought maybe I had pulled a whole batch of muscles in my chest from the moving and things like that. And so I took some pain medicine, I went home and I crashed, and he also said to me, "Lois, I'm going to give you some antidepressants." And I looked at him, I said, I'm not depressed, I'm in pain. We heard that this morning a couple of times, if you recall. And he said, Lois, I know you're not depressed, but as long as you stay in pain, you're going to start getting depressed. And I had to admit he had a point. But he said, the reason why I want to give these to you is because you will sleep. And if you sleep, you will heal. If you heal, you'll feel better. Well, his logic made a lot of sense to me. So I said, okay, I'll take them. And I went home. And that was the beginning of a very long, painful process. I would go back weekly, sometimes more. The pain was worse, and the pain had moved. And we really ran out of what it could be. It obviously was not pulled muscles. So Tom sent me to a specialist in Great Falls. At that point, we only had a handful, if that, of rheumatologists in Montana. We had none in Helena at that point. And, you know, that was good, but it was bad. It was good because he helped get the diagnosis. It was bad because he was condescending. And I was in no mood to have condescension. I wanted information. And so what he said to me was, oh, women always feel pain. And I looked at him and I'm thinking, and my husband's looking at me, and I can tell he's saying, don't do it. Because I would have. And then he said, oh, you know, you have a low threshold of pain. First time he had met me. And I'm sitting there going, 25 hours of labor, I have a low threshold of pain. Let's try this out, Guy. What we had was a miscommunication. And I'm going to speak about communication a lot. Well, after a few fights, because I can be feisty even when I'm in pain, we did come to an understanding with one another. And he actually turned out to be one of the best things that happened to me after, you know, we decided to bury the hatchet and actually talk to one another. He gave me a TENS unit. I loved my TENS unit. My TENS unit allowed me to function. I was still in pain, but hey, you know, I really didn't know it. I wasn't taking pain medicine. And that helped me tremendously. He also said to me, you know, we're just not going to deal with drugs. And I was pretty happy about that because I really didn't want to just deal with drugs. He said, I want you walking 2 miles a day. No, my husband went unhinged. And he said, she could hardly walk from the parking lot to your office. Are you nuts? And when the doctor explained to us that, you know, no, he really wasn't nuts, that this was actually a very good therapy and this was something that would actually help me, it did. It took a while. It was very painful. But you know, one thing that it did, it brought back my love of music. Now this was, of course, the 80s. And so I had a Walkman, not a DVD player hooked up. But I listened to music while I walked. As I got better, because as I got better, I walked it faster, my daughters joined me. My dogs joined me. It became family time, which was so needed by all of us. Because my daughters were very little. One was 14 months old, the other one was just 6. I never was able to pick up my 14-month-old daughter again. I couldn't stand the pain. But you know, she was a smart little one, and Paul actually knows her. And she learned a way that she could hug me, and that she could snuggle with me, that just brought joy to both of us. And we never lost that connection. There was also another treatment that we did at home, and for some reason I can't remember the name of it. But my husband would have to put electrodes on me, and he'd have to put medicine in, and then that medicine would be forced through the electrodes through a battery-operated machine. One night when she saw him doing it, it was the first night, she came running in, screaming and yelling at her daddy. She's beating on him, saying, "No, no, you hurt, you hurt." And we kept saying, probably too well, "No, this is mommy's medicine, this is mommy's medicine, this will make mommy better." Well, after Bill finished working on me, she comes running in from her bedroom with an armful of toys. And she placed them on my chest and shoulders, wherever the electrodes had been. And as she put them down, she said, "Mommy's medicine, Mommy's medicine, Mommy's medicine." You better believe I felt terrific that night. And actually, when I told Tom Norris that story, he started crying because it was so moving. And I guess you have to know Amy because she could be a real pain at that age. So we grew as a family. We tried to learn what was going on. And then Dr. Norris leaves, and I did go into a Great Depression. Now Tom, and I told him it was the only reason why I could let him leave Helena in Montana, is now teaching at the University of Washington Med School. And I said to him, if you sent out one more doc like you, it was well worth my losing you. So he gave me to one of his junior partners, Dr. Mike Streckel of the same clinic. Mike has been my doc since then. It's like 22 years. And we have gone through many things together. Now, I'll admit, in the beginning, we had some miscommunication. I mean, Tom had broken me into being a patient, and I had broken him into being my doctor. And I had to start all over again. And it was disconcerting. But, you know, we ironed those all out. And I just want to give you an example. As you know, I'm a librarian at Carroll College, and I, of course, have to look things up. So I looked up some synonyms for pain. Ache, pang, prick, smart, sting, stitch, throw, tingle, twinge. I don't use any of those words. The related words: discomfort, distress, soreness, tenderness, agony, anguish, misery, suffering, torment, torture, inflammation, swelling, damage, heart, hurt, injury, backache, bellyache, Charlie horse, colic, earache, grip, headache, stomachache, toothache. So then I wonder what they say about hurt. Because hurt and pain a lot of times is used. And those synonyms are ache, pain, smart. I never walked into my doctor's office and said, you know, I have a smart pain. The other words, related words, are cramp, fester, itch, nag, pinch, pound, rack, sting, swell. You get the picture. Communication is so important. Mike needed to know when I walked in and I said, you know, I'm sore today, that meant I was really doing pretty good. But if I came in and said I was in pain, that we were looking at changing my pain medication, at least temporary, until I could get it under control. The pain meds never took the pain away. It took the edge away. And as long as the edge was gone, I was able to deal. I learned a lot of coping skills. And I learned that one of the things I grew up in my family that worked the best was laughter. We could find something funny to laugh about, we did. And so, you know, the kids, when I'd be leaving as they were older, you know, for my walks, they would say, well, if you're not back in a half hour, we'll we'll call the sheriff to go look for you. And I'd laugh. They actually, well, they didn't call the sheriff, but they called my husband because I was late one time coming back. I also decided that, you know, I didn't ask pain to come live with me. So I wasn't going to be a very nice landlord. And so it has to deal with my rules, which is not to give me any pain. And so I do block it down a lot. I do take some pain medication. There's some aches that don't work. And so I don't bother taking anything for it because I know it's not going to do anything for me. And as I said, I learned to really lock that pain away. So, I think, information is power. I like dealing with physicians and healthcare professionals that will give me the information. Don't sugarcoat it. Tell me what it is. Spell it for me so I can go research it. The physicians and healthcare providers that don't get along as well with me or me with them are the ones who won't share information. I thrive on it. And to me, a patient has to be an active participant in the process, whether that's dealing with the doctor, the PT person, or else. I said I'd share a bad story, and that I want to share that in one good story. A bad story. About 1988-89, in St. Pat's in Missoula had a conference on fibromyalgia, and my physical therapist urged me to come, and I came. Every speaker who got up looked at the people and said, "Yes, you are in pain." People cried throughout that entire conference. Well, I found out at the break, because people would say to me, "So how long was it before you got diagnosed?" And I said, 9 months, and they said, "Oh, you're lying." And I went, "No, 9 months." It took them 25 years because they were being told it was all in their head. That should not ever happen, even if there is a position for that. The good news is Mike Streckel is my umpire. He's the one when I've had cancer, I've had other things happen. Mike is the one I go to. Mike picks my doctors throughout the state. He's told me, if you don't like someone, if you're not comfortable, tell me. I tell him, he finds me someone else that I can work with. We have a trust and we have an understanding with one another. To me, he's my rock, and I've told him he can't ever retire, or he has to just move into my house and be mine. So health providers are extremely important. You need to understand what patients are saying and how we're saying it. And we need to understand you also and trust you. And for me, it's sharing of information. For others, it may not be giving you the information, but someone in that family needs it and needs it desperately, because you don't have one patient, you have a family. Thank you.
Okay, the next speaker is going to be the world famous Catherine Bourgeois.
Oh my God.
And I think you just heard her introduction. Catherine practices internal medicine and geriatric medicine, and she is the director of the Hospice and Palliative Care Center over in Bozeman at Bozeman-Dignan. So I will turn it over to you.
Okay, now Kay, I need a little, Kay, is there a way to find this? Oh. Okay. And while Kay's helping me with the computer, because I'm really not computer literate, I need to just, actually, I want to return this. I'm not going to return the award, which I really appreciated, but it's really, Kay and Kristen are the rocks, really. And they're the ones who deserve the award, so. And the only reason I'm doing PowerPoint is because it's dinner and because I'm not sure I could remember stuff otherwise. So, what I did is I titled this talk, "What's a Primary Care Provider to Do?" Because I wear many hats. In a small town, you do that. So I do primarily geriatrics in the clinic 2 days a week. I'm in the nursing home 1 day a week, and I'm also medical director of our hospice and palliative care program, and then sit on too many committees. And that's sort of the nature of a primary care physician in a small community. So this is ditto. Basically, what everybody has said today is a little bit, I'm going to repeat myself a little bit because everybody has really sort of said stuff, but I'm going to try to put a little bit of a personal spin on it. I did want to tell you what the difference between a pit bull and a palliative care doctor is, and the answer to that is, I haven't a clue. But there are some people who think of me as a pit bull. So, and then this is a cartoon. I see here several good deeds that seem to have gone unpunished. When I was a kid, my dad always said, no good deed goes unpunished. And it's sort of a mantra I've lived by in some ways. But it also reminds me of my dad. And I guess one of the things that I bring to this is that we all bring our own experience to everything we're doing. And I'll get into that at the end in a little bit. So there are a number of concerns. There's professional concerns, there are societal concerns, and there are personal concerns. And I'll address all of those, and then hopefully we'll have enough time to talk about what we're trying to do in Bozeman, which we're just really it's one step at a time. And one thing that I was reminded about today is that it's really small steps. And I just want to tell you about one patient that I saw yesterday. She's a 75-year-old woman who'd been seen by one of the internists in our practice for a while. He sent her to me to help with some of her pain management. And she came in to see me yesterday, and she sort of has her cane, and she sort of walks very slowly. And I don't even remember what her pain diagnosis is. But she sat down, I said, "How are you?" She said, "I am great." I said, "What do you mean?" She said, "Well, I can go for 5 minutes without having to either lean on something or sit down." And it really struck me, because we've heard today about function and how function is so important. But it's also what's important to the patient. This patient, to be pain-free for 5 minutes at a time, that was fabulous for her. And I thought, wow, I don't know what I've done. I adjusted her meds a little bit, but somehow that was what mattered to her. So there are a lot of professional concerns, some of which we've already heard today. I do think, despite what we think we know, there is a lot of lack of data, and there's conflicting data. I recently went to a course in Boston at Harvard Medical School, their pain course that they do every year. And then I recently came back from a conference in Chicago from the hospice medical directors. Well, we're dealing with two very different pain patients, but the difference between how the Harvard was addressing issues around opioids and how the American Academy of Hospice and Palliative Medicine physicians were dealing with opioids was completely different, as was their approach to methadone. And so I think as primary care providers, we're getting all this conflicting data. Plus, there's a lot of data that we don't know. We really don't know, as much as those wonderful graphs and pathophysiology and stuff, we're really not completely sure how a lot of these medications are working on our patients. So that's part of the big problem, I think, for primary care providers, is that, people say to me, "Where's the data?" And I'm not sure I really have the data to give to them. There's a lot of lack of time. Patients who have persistent pain, or patients who have cancer pain, or whatever kind of pain, or even acute pain in the hospital, take a lot of time. What do we as primary care providers not have is time. Okay, so that becomes a big issue in terms of how to take care of patients. Lack of interest. I think trying to get somebody out of pain is amazing. I think if I'm successful at that, I have a great day. But I will tell you that this is not something that a lot of primary care providers really want to do. They're not that interested in this as a disease. They'd much rather deal with a lot of other different kinds of things. And this is I'm not being pejorative to my primary care colleagues. I'm just saying this is the reality of what people are facing. I think there's also a lot of bias from primary care providers, and some of that comes out of societal concerns, but some of that also, and I was talking with one of my colleagues earlier this evening, is that whole issue of abuse, addiction, and pain, and that person being in pain and having to believe them, but having our own biases about whether they're really in pain or not. And I run into that all the time. I also run into the issue of physicians being concerned about liability. And I'll talk about that in a minute. Fish or cut bait, fish or cut bait, fish or cut bait. How fishermen blow their own minds. My husband's out there fishing right now, and I'll see how he returns. But some of this is how we have to deal with patients who are in pain. Societal concerns, and we're going to hear a lot more tomorrow about the law, and I know Scott Fishman is going to be talking tomorrow about the law, but I think there's a lot of misconceptions about the law and what they expect physicians to do. There's a lot of fear out there, and the reality is very different. I'm not going to go through with you all the different cases that have come out in terms of malpractice, or in terms of the DEA and all that kind of stuff, but there's a lot of misconceptions about what's going on out there. And some of the seminal cases that have come out in terms of the legal system is that there are a few more important cases about undertreatment of pain than overtreatment of pain. Okay? As a matter of fact, the one that was key in California that made them make the ruling that everybody in California, every primary care provider, every physician, in order to renew their license, has to take a CME course on pain, was because of a case of undertreatment of pain. So I would tell you that there are as many undertreatment cases as there are overtreatment cases, although I'm sure I would get arguments about that. Insurance. I have to go and go to a risk management course in 2 weekends through my malpractice insurer. And the reason I'm doing that is because I get a break on my malpractice premium if I go to this course. It's a day-long course. The first session is an hour-long session about opioid prescribing. Okay? This is the first year they're doing this. I'm going to be really curious to hear what they have to say. If you think I'm not going to speak up, you're probably wrong. But, you know, I saw that and I thought, you know, again, they're just, you know, there are a couple of docs in my practice who come to me and say, well, the liability and the this and the that, and it's not about liability, it's about good patient care and it's about knowing what to do. The press likes to sensationalize. And I know that we had somebody here from the Missoulian earlier today, which was great, because there were a number of articles that came out recently, right before this conference actually, about a month and a half ago, that again sensationalized the issues around opioids and abuse. Now, mind you, I do believe that there is a problem in terms of abuse, but I think that we're looking at two dual problems. One is the undertreatment of pain, and the second is that there is an issue around people abusing pain medicines. Absolutely, it exists. It's across the country. It is on the rise, but it's the tip of the iceberg, and the undertreatment of pain is probably the rest of the iceberg. But that's what gets written about. I think access to care is a big problem. At the conference I was at from the hospice medical directors, I was talking to somebody from Tucson, which is a fairly sizable city, and some of the issues that we have around having providers who are skilled in dealing with patients with pain were some of the same problems they were having in Tucson, and I can guarantee that it's probably across the country. So we have this sort of microcosm in Bozeman, but I think it's everywhere across the country, and we just don't have all the resources that we could need. And then access to care. At the end of today, we had a great talk about integrative medicine, CAM, whatever you want to call it. And we have a lot of integrative docs in Bozeman. We have a lot of naturopaths, we have a lot of chiropractors, acupuncturists, craniosacral people, all sorts of different kinds of therapy, which I truly believe really helps a patient who has persistent pain. The problem is, what does insurance pay for? And I know we have a couple of insurance people here, and I'm not trying to put the blame on you or anything, but there is a real issue in terms of access to that. I deal with Medicare patients. Medicare pays for chiropractors. Okay? They will pay for physical therapy, and luckily in Bozeman we have a physical therapy group that all their physical therapists are also trained in craniosacral massage. So that's a great resource for us. But a lot of my older people cannot afford to go to an acupuncturist or somebody else whom they might really benefit from in terms of their persistent pain. Before we try assisted suicide, Mrs. Rose, let's give the aspirin a chance. This is really the only reason I get the New Yorker, is because although I did grow up in New York, and so I've always gotten the New Yorker, but mostly it's for the cartoons. So I want to talk about a couple of individual concerns and why I think I got involved in this, or what I am still seeing as a practitioner, because again, as a practitioner, we bring to our practice our own experience. My sister is a chronic persistent pain patient, has been for years. She's quite functional. She works part-time. She's a Feldenkrais instructor, which is another kind of gentle massage, integrative medicine, whatever you want to call it. And she's now on a good regimen, and she has a good doctor. But it probably took her 10 years before she was not treated like an addict. And it used to drive me nuts because all she was trying to do was get her pain under control so she could function. And yet what was happening to her instead was she would go see these various doctors who'd say to her, you have to come back every month to see me because I'll only give you a month's prescription, which is not the law. You have to try to get off the opioids, okay, because they're bad for you. And so she very diligently, because my sister's a pretty responsible person, would diligently try to get off the opioids. What would she do? She'd then withdraw. You know, so she really had, it used to just infuriate me, the kind of treatment that she got from my own profession. I recently had an experience with my mother-in-law, who's 82, and this is how humble I become around helping people with pain problems. She had a compression fracture. Went to the hospital, got a kyphoplasty. It really didn't work. For better or for worse, sometimes it will work, sometimes it won't. So she ended up on opioids. She then actually got a second compression fracture. But what was really bad is that along with her acute pain and the opioids that she needed for her pain, she got terrible constipation to the point where I think she was up to, I don't know how many Senna a day. I finally got her mag citrate, and at one point we took her to the ER to get disimpacted. And this was my mother-in-law, and here I was like, I am so messing with her. And I should know what I'm doing, but I couldn't help her. As it turns out, she also, in the middle of this, was getting delusional. Turns out that not only was she delusional from the pain meds, but she had Lewy body dementia on top of it. So, you know, here I was trying to deal with all these complicated things, and I couldn't do it. She's better now, and she's no longer constipated. So, in case you were wondering. And then, just in terms of myself, I don't have really bad chronic pain, but I don't know if I have chronic piriformis syndrome or SI, whatever, but I spend a lot of time taking care of myself physically because otherwise I will get into pain. And I suspect there are many of us in this audience who have to really take care of themselves to keep themselves out of pain. I'm getting there. So, solutions. Maybe. And I say maybe because we've heard a lot of ideas today, and I was really excited. One of our nurses from the emergency room was here from Bozeman, and she just was so excited about that whole headache pain that Paul talked about, and she's just ready to run with it. But my experience has been, you know, it's little steps and slowly. Well, time for our weekly brainstem storming session. Okay, so some of the solutions are CME. Unfortunately, the experience in California has shown that the CME helps, but not that much. The place that's really had the best experience in terms of pain education of physicians is in Oregon, where they had the physician-assisted suicide law, and what that did is it made every doctor get really educated in terms of opioids and opioid prescribing, and they do a really good job in Oregon. Mandatory training for hospital employees. We now have the nurses doing mandatory training. Doing it for the docs is a little bit more difficult. So, as somebody said, it's like herding cats. So we're working on it, but it's an issue. And then I think one of the biggest things is really educating the public and doing what you did, which is really advocate for yourself and teaching the public how to advocate for themselves around pain. Power Over Pain, you have in your handout actually their monthly newsletter, which I think is really quite good. Kay is involved with the Power Over Pain program, which is a national program, and it looks at responsible and balanced advocating for patients with pain, helps understand individual state pain issues, and promote pain awareness. And actually, it's a great resource for us through for the Montana Pain Initiative, which I think we'll talk about more. And I'm going to skip that because I think we'll be hearing more about that. And then institutional change, which is really where I think we need to be working. I think we need to be working in our communities, in our own institutions. So we have an active pain committee in our institution. Sometimes it gets stuff done, sometimes it doesn't. I want to credit Pam Hebert, who's one of the physicians who I work with, who runs our pharmacy committee, and we were able to restrict meperidine or Demerol in our institution. I see that somewhat as a personal victory, since I tried to do that about 15 years ago at another institution, couldn't get it done. So we need to be looking at all of our different resources and how we can pool them together, and then look at different models for pain clinics and people with persistent pain. So we don't have the resources in Bozeman to do a full-fledged pain clinic. So one of the things that we're looking at, and Scott Fishman may talk about this tomorrow, is doing some kind of scaled-down thing in our primary care clinic around persistent pain. He has an article that if anybody wants a reference, I can get it for you, called the Trilateral Pain Contract, which is between the patient, the primary care doc, and the chronic pain doc. And I don't consider myself a chronic pain doc, but I could do a consult on a patient and say, this is what I would recommend. The physician, I would sign it, the primary care physician would sign it, and the patient would sign it, and that patient could then periodically come back and see whoever we have to do a pain consult. I don't know if it would work in our setting or not, but part of it would be really a systematic evaluation of the patient at the beginning, including issues around abuse, and then persistent reassessment, which is where I think we fall down, and also looking at what we heard about earlier, which is the issue of functionality. Then doing something around headache, and there was one other thing, but look at your community and see what you can figure out. Then finally, we have 4 dogs, unfortunately. And this is the one, if anybody wants to adopt it, we'd be happy to give it to you. Anyway, thank you very much, and I'm just so delighted you're all here.
Our next panelist is Shelley Schellenberger, who's a nurse and the medical surgical director at Northern Montana Hospital in Havre. She was the lead on the Pain Policy Improvement Project, which resulted in pain policy change for in- and outpatient there in Havre, both long-term care, home health, and hospice. So Shelley's going to discuss with us, in some ways, how you get this done in small-town Montana. Is that accurate?
Sure. I kind of laughed when Kay called me and asked me to do this, because I think one of the reasons she asked me was because I'd actually called her. We'd had some issues when we got started with our program that centered around some hostility in the emergency room nursing, and so I think I'd asked a question, and therefore then I became one of the people. Then I became one of the people that she focused in on. So anyway, there's 2 parts to my talk, and the first part's kind of easy because what we did in Havre, we took from the beginnings of the Montana Pain Initiative conferences. There was a group of us that attended the first one, and we left here with an inspiration that just was incredible. We were inspired by the people that talked to you today. There were many of those same people at that conference. And unfortunately, for those of you that didn't get to hear June Dahl, she was very inspiring also. So we went back to Havre and we formed a pain committee, and that committee, in Havre we're really lucky. Our entire facility is acute inpatient, outpatient, home health care, hospice, long-term care, and the clinics were all one big happy family. And so we got people from all of those different disciplines in the nursing aspect of it, and then we brought in our medical physician, and we just started brainstorming, and we looked at what we had for current policy, and we knew that we needed to make some changes. If you're a nurse, you know that reassessment's a big issue, and that though you may ask the question, you very infrequently document the answer to that question. And so we felt we had the opportunity to do an assessment across the board of all of our facilities and really guide how nursing was going to ask questions and how that was going to be documented into our medical record. We're also very lucky in Heifer. We're all electronic in the nursing aspect of it. And so we had the opportunity to be able to disseminate that information throughout all of our facilities. We did a complete overhaul of our policy to begin with. We did a complete overhaul of our documentation. The way that we did that was the simple way. We took what we had learned and what we could find on the internet from other resources, and we just said, we know we need to do this. We need to ask about intensity, we need to ask about location, we need to ask about duration, and we just started building things. And we went into our system. We are on Meditech, and we were able to do that. We knew that we had a lot of work ahead of us as far as education, but we made our in-services mandatory to our nursing staff, and so we ended up with 9, 10, I don't know, something like that, sessions of education, but it went well to begin with. In our planning stages, we knew what we were going to do. Where it became an issue was when we actually got down and did the education. That's when we encountered sort of an in-your-face hostility about the fact that we were trying to tell nursing that people who have pain deserve to need to have pain medicine, and we had not addressed in any way, shape, or form what they saw as their bigger problem in the emergency room, and that was diversion and drug seeking and whatever other negative term you'd like to use there. And we tried initially to really say, that's not what we're talking about. We're not talking about the person who's coming in that wants pain medicine that really doesn't have pain. We're talking about undertreatment of people with chronic pain or acute pain, and we really want you to get better at that part of it. And they kept saying, I can't even see that part of it because I am so blinded by these people here. And so we said, but can we just put them to the side for a minute and can we talk about this? And eventually in the first session that I did, we did get to that point. They were able to, after about 10 minutes of almost yelling at me, we could come to an agreement to put that part aside and to look at the chronic pain management in a person who we know has a reason for pain or has documentation of long-standing pain, who comes into the emergency room and needs more pain medicine because either they're out because they had an exacerbation and they've been taking more than they normally do, or they had some secondary injury. But what that did for us is it actually kind of stalled us out, because all of a sudden now we knew that we had good documentation tools, we knew how we were going to assess pain as being the nursing staff, but we didn't know how to handle the negative side of what the nurses were seeing. And the unfortunate thing then was that we, the people that had started all of this, are now sort of dispersing. Our acute inpatient ER ICU director has been deployed now, so he's gone. Our long-term care director is in the process of leaving. And so I ended up being one of the mainstays of the people that started this, along with our home health care hospice director, and Lisa Genero's been very active on the state level in different programs with pain management. So she's good staff, or good help, but she doesn't have a lot of staff, so she tends to run her department and work her department. And that becomes an issue. I think, though, that what I want to tell you that most of all is that it's alive and well, that bias that Dr. Borniak talked about, that concern that the nursing staff has that they're really going to do something that isn't going to be helping a patient, but rather allowing for somebody who's doing something illegal to do that. And that really scares them. That scares them more than than it does to almost go the other direction. So they look at people. We had a patient in that I spoke to just recently that had a fracture, and she had an injury, so a fracture. We knew she had that. She did her follow-up post her ER visit and ended up with some complications to her fracture, so they knew they were going to take her to surgery. But in the meantime, she ended up back in the ER about 2.5 days after she'd been in for her follow-up appointment. And the ER staff felt she was drug seeking. Now, she had a fracture, and we knew she had problems with her fracture. And they still gave her the feeling, and she said, this is all me. I really just feel that they thought I was drug seeking because I'd gone through all my pain medicine. I was taking it more frequently than I was supposed to. And it was what the nursing staff felt was textbook drug-seeking behavior. And I'm looking at it from my side of it going, but wait, what are you doing about the fact that she has complications to her fracture and you know she's going to surgery in 2 days for those complications? It's just unfortunately alive and unfortunately well, and unfortunately needs to be addressed in some way, shape, or form. The nursing staff knows that part of their problem is that there are patients that we see that are not happy with their primary care physician or their primary care choices, so they come to the emergency room because they know they need to be treated, and they feel that that relationship that they have with those patients can never be what it needs to be in a chronic pain situation. They know that they can never develop a trust with those patients because they don't see them routinely except for every other week or something to that effect when they come into the emergency room. But they also recognize that those patients aren't able to develop the relationship they need based on the things that are available to them for options in seeking pain medicine. We're 110 miles away from Great Falls, which is a huge issue. Transportation becomes a huge issue in our population. It's just, I don't think I have any solution whatsoever to this, and that's why I came here, was to look to this to see what we could do for our staff, to give them some guidance and to give them some direction, to give them some hope, I think. And the other thing that I think is interesting, we talked a lot today about electronic record. One of the things I think you need to hold in the back of your head is that electronic record is very helpful, but it can also be a hindrance. One ER nurse I was talking to about this, she said, you know what? We had this patient come in, I didn't know the patient. But I went to the record and I found out all this information about previous visits. And I had a preconceived notion when she walked into the room about what she was going to be telling me and why she was going to be telling me it. So even though it's great that you can share information, you need to do it with regard to the fact that there's still incidences that are going to happen that you shouldn't be thinking about the past. And I think that their other issue becomes the fact that they feel like they become the clinic and they're not there doing what they love to do. They love the trauma, they love the acute episode, and the clinic dumbs them down in some ways. And if you've been to an emergency room lately, I was in there with my daughter a while back, and it was interesting to me because there's more of a clinic mentality at certain points, in that there's not the rush, 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 but rather the, okay, these are our 4 patients who just have these problems and we can just do it and we don't really have to get them out of here. And I think that's something that we need to think about closer when we make a judgment about what the emergency room nursing and the emergency room staff is doing, is because have we really turned it into something that it's not supposed to be? And that's really it. Thank you.
Our next panelist is Mr. Paul Peterson from Blue Cross Blue Shield. Mr. Peterson and I go way back, I guess. 20 years, he told me, so I told him not to tell anybody else that. I think that one of the barriers that clearly is a problem for all of healthcare today is trying to solve the issue with insurance payment, how we finance healthcare, and that comes really home to roost in chronic pain management, because everybody's been talking about how much time it takes to really adequately treat a chronic pain patient. And unfortunately, that's cognitive time. And we're still struggling with this disconnect between, doing something to someone that's attached to a CPT code, that is attached to a price, and that's the way medicine is going. What we've been talking about today is something that is very manpower intense, very resource intense, but it's about time. It's not necessarily about procedures, about expensive interventions. Sometimes they are, sometimes they're not, but it's about time. So I think you should keep that in mind, and hopefully Mr. Peterson is going to give us a perspective on the challenges that the insurers are faced with in terms of trying to help us help our patients. So thank you.
Got to adjust this.
Yeah, I had it down a little too high.
Good afternoon. Thank you, Dr. Seacrest. Thanks for the opportunity to be here. My name is Paul Peterson with Blue Cross and Blue Shield. Catherine, certainly no offense taken. We understand. I am not a clinician. I will start this off with that. I have been with Blue Cross for 20 years. I've been in the healthcare industry for an additional 5 years. I've been a pain patient once. Actually, my only hospitalization in my entire life was a result of back pain. And that was episodic. And I still commit 20 minutes a day to a series of lumbar stabilization exercises with the belief that the elimination of pain is my motivation. That admission was actually 12 years ago. But to this day, I've lost, I think as Lois can attest, I've lost 70 pounds. I exercise 5 to 6 times a week, continue to do my lumbar stabilization, because pain or the absence thereof is a significant motivation for me personally. But what I'm going to talk about today is I'm going to try and very quickly go through, as Dr. Seacrest had intimated, a perspective from a health plan's perspective. And today with this group, of course, it's pain management. Access to effective pain management. That's the topic. But you can understand from a health plan's perspective that there are other protocols, there are other services, there are other techniques and specialties where the same process and the same perspective would come to bear. So very quickly, on the definitions, again, access, defined as the ability, right, or permission to approach, enter, speak with, or use. Effective, adequate to accomplish a purpose or producing the intended or expected result. So if we were to take the topic of tonight's panel, the ability, producing the intended or expected result of effective pain management. What does that look like from a health plan's perspective? Again, I'm looking at this from 3 perspectives, and you will see unrehearsed that I touch on, I believe, several of the points that Catherine spoke about, that Lois spoke about. And I'm going to go into a little bit of detail with respect to that. The first is knowledge. I'm going to take the health plans first because I don't want Catherine to believe that we'll, save that for last when I get the 3-minute sign and I gotta go. No. A health plan's role is knowledge. We need to accumulate knowledge, and we need to understand the clinical aspect as well as what do our customers being purchasers of healthcare, what is it that they want? So we need to be able to take knowledge that is evidence-based, that is able to be reproduced, that has an efficacy that is demonstrated. And we need to couple that with what do the purchasers of health insurance want. So we need to take that knowledge and synthesize that knowledge then into a benefit plan, That benefit plan then needs to have a price. And that price needs to be able to be taken to the marketplace and a value associated with that where a purchaser says, I'm willing to give you money for the value of that benefit. We then need to take that benefit and put it into a series of instructions and codes, as Dr. Seacrest mentioned, and to be able to process a claim when the claim comes in for that benefit. We need to be able to educate our members, not the purchaser, because remember in our system it's mostly group-based, and the purchaser pays an inordinate amount for the overall package. The member, the ultimate consumer, pays less, although that's growing, but the member pays less. And the member needs to understand how to use that, what that benefit is, and how do they access effective, in this case, pain management within the construct of that benefit design. So we need education to the member. We also need resources. The member needs to understand, if the member is going to be successful in the navigation of our healthcare system, the member needs resources made available to them. They need a benefit design that's understandable. They need a network of physicians that's accessible. They need resources within the health plan to allow them to understand what that means to them. And by extension, when I talk about the patient, or the member, I'm by extension talking about their support group as well. So not only the member, the family, the dependents, but the support group that represents that unit. Collaboration and communication. The health plan's responsibility is we do need to collaborate. We need to collaborate with the clinical experts, which a lot of them are in this room. We need to communicate with the member. We need to communicate with the purchaser. And we need to collaborate. We do not have the answers. We have a piece of the answer, and we need to collectively come up with that collaborative approach. So communication, excuse me, is critically important. Provider recruitment, I mentioned it before. We have a benefit structure, but for the member to effectively access that, then we as a health plan have to recruit the appropriate provider. And not only the appropriate providers, but at the appropriate price that support that benefit structure. So we need to then go out and recruit the geriatric subspecialists, the pain management specialists, the physiatrists, the physical rehab physicians, the mental health components. That is the health plan's responsibility. And then education. And we need to ensure that we are, through that collaborative communication perspective, educating the providers as to that benefit. Okay, so that is the health plan's role. And trust me, in the 20-some years that I've been in the industry, that is greatly condensed. Because I think, as anybody up here can attest to, our industry is very, very complex. But for the sake of our discussion, those would be the responsibilities of the health plan. Now, the patient's role, you will see there is a lot of similarities in the role. But the responsibilities are going to be significantly different. The patient has a responsibility, or the patient's unit, support unit, if we will. They have a responsibility as well. They need to make themselves, to the extent that they're capable, they need to make themselves informed. Because again, knowledge is critical to accessing effective care, whether it's pain management or any care. They need to understand. They need to understand the benefit structure under which they are covered. which provides services to them. You think about it, and again, whether you're on an individual policy or on a group policy, the annual cost of that is somewhere between $8,000 and $12,000 on an annual basis. That's the cost. The next item, the summary plan document or the member guide, that's like your owner's manual to that $12,000 product that you are paying for. That owner manual provides information, specific information as to what's covered, what's not covered, what's included, what's not excluded, what your responsibility is, what the physician's responsibility is. And I would suggest that in our market, even at the price of $12,000, a lot of our members, your patients, your customers, they don't have a clue where that SPD or that member guide is. Again, that's not meant from a pejorative perspective. They can certainly find their owner's manual for the flat screen or the iPod or the DVD player, but for their health plan, they can't put their hands on it, nor do they care. That's, and so we have to, as an organization and as a society, we have to shift that process. The third thing is collaboration and communication. Lois, I think, talked about it wonderfully. Catherine talked about it. Shelley talked about it. The patient's role is that of communication. They need to be comfortable communicating with their physician what they're experiencing. If they're unhappy with the feedback from the physician, they need to feel comfortable in sharing that with the physician. I'm sorry, doctor, my feeling is that that's condescending. Can we reframe that? I mean, we need to have that healthy dialogue that allows for two-way communication. Collaboration. That communication needs to occur with the family unit. The collaboration and the communication needs to occur from the specialist to the primary care physician or the individual charged with the management, overall management of that care. Member advocacy and resources. The individual, the member, the patient needs to understand what resources are available for them. It is complex. It is difficult to navigate, but it can be done. And if they need help, there are resources both at the health plan, at the city level, at the county level, at the state level to assist in that. Thirdly, from the physician side, knowledge again. The physicians are highly skilled. The medical practitioners are highly skilled individuals that are providing very appropriate care. I don't believe anybody refutes that. Care delivery is what they do. I think the reference to time is so critical. Time is the only thing really we have. And the demands on primary care, and as Dr. Seacrest had mentioned, the time on the cognitive aspect of care delivery, that's a critical piece. Benefit design, it is the health plan's responsibility to design the benefit, but the provider, and by extension their staff, it's to their benefit to understand how do they maximize time and benefit by working efficiently with the health plan, by using electronic transactions, electronic services, by being able to effectively manage their patient load. Benefit administration, when we compensate for a service, then we want to make sure that that compensation is timely and fair and equitable. And the physician wants to be sure that they were paid. So that there is a collaborative approach from that perspective. Member education, I think you've heard it all. The physician does a tremendous amount of education on the patient's behalf, and from an advocacy perspective as well. So I think from our perspective, from a health plan's perspective, you see the roles are very, very, very similar when you look at the constituency that makes up that care delivery and care financing system. The responsibilities who we're doing it with and for why are different, but the roles are the same. So from that perspective, I would go back to the point that collectively is how this is going to be resolved, how access to effective pain management is going to be reached. And that is not the patient's sole responsibility, nor is it the health plan's sole responsibility, nor is it the medical practitioner's sole responsibility. To meet that challenge, it's going to require all of those constituencies working together. That's what I have. Thank you very much.
Thank you. Our final speaker for this session, and then we'll take questions from all the panel members, or to all the panel members, is Peter Strauss. Mr. Strauss is the, is your title, the Vice President of Operations Support at Montana State Fund. And I think this is a similar discussion in some ways, but I think everybody in the room would agree that the work comp patient is probably a little bit more of a challenge because of some of the other issues that hover around a workers' comp claim that aren't operative necessarily in the private insurance arena. But you'll clarify for us.
Absolutely. Absolutely. I'll provide clarification to the best of my abilities. I want to thank you very much for being here. The last time I had a presentation that started at 8 o'clock at night, nobody was sober.
What makes you think we are?
Well, you're not asleep yet, but I'll take that challenge. And the number of people at this table was more than the people I presented to. So if nothing else, I want to thank you for your intestinal fortitude for sticking it out. Turn it up? Okay. Thank you. I was most pleased when I got the invitation from Kay to speak at the pain conference. My staff told me this was a perfect fit because I was a carrier. We have a number of positions open at the Montana State Fund. I want to try to address the two questions that you have provided in the white paper. How are pain issues treated in workers' compensation, and what would comprehensive pain management look like under workers' compensation? I think I've got the answers for those. And when I read the paper, it was very interesting. Kristen, when she checked me in this afternoon, was most enlightening and delightful. Thank you very much. I knew immediately, however, that we had a communication disconnect. Because when we talk about workers' compensation, from my perspective, you're the doctors. You say the patient needs this. I don't have a whole lot of options under the Montana system. Different states are different. And one of the things we go through in workers' compensation, each state law is different. What's an injury in Montana is not necessarily an injury in Nebraska under workers' compensation. So, I've livened you up a little bit with some humorous statements. This is the audience participation part of the panel. For the $50 prize, what is workers' compensation? Now let's not always see the same hands, please. Let's see, some hands? I'm serious. What do you think workers' compensation is?
It's an insurance that covers workers in case of injury.
An insurance that covers workers in case of an injury. That's a pretty good start, pretty high level. Anybody else want to take a shot at it? You're not wrong. I'd like to get a little bit more detail. If you're hurt on the job, in the course and scope of employment, $1 medical coverage to treat for that injury is covered, is paid for. No deductible, no copay. If as a result of your work-related injury, you lose time from work, a portion, not the entire, wage, a portion of your wages are replaced tax-free. That's all workers' compensation is. Medical benefits paid to the people who provide medical care, wage loss benefits, which the insurance industry insists on terming indemnity. We can't make things simple. We can't speak English. It's, when you take a job in this industry, you have to learn to speak a different language. The benefits are defined in state law. Okay, how many of you would characterize yourselves as employers? That is, people who purchase workers' compensation. Okay, let me ask you a fast question. What are your workers' comp policy limits? You don't know? Do you know? Sir? Your workers' compensation policy contract says we will provide benefits as required under state law. It's not 50,000, it's not 100,000, it's not $1 million, it's not 5 million, it's not 10 million. It is benefits as required under state law. Workers' compensation is a state law program. There are no limits. In fact, medical under workers' compensation is a lifetime benefit. Lifetime benefit. Depending on the state and the time, some indemnity, that's the wage loss benefits, are also lifetime benefits. I started work in New York. Actually, I started work in New York, and I'm a recovering New Yorker. Doctor, can you relate to this?
Sort of.
And you know the difference between New York and New York? It's about Poughkeepsie.
Yeah, right, that's right. Yeah, oh yeah.
And when I started in the late 70s, we had a claimant, a widower, who had been collecting widow benefits since her husband had died in 1915. This is a lifetime benefit. So my perspective is a little different. We're not talking about designing planes. We're not talking about provider education, although there's nothing wrong with that. We should be part of that. Let me give you another perspective as well. Workers' compensation represents about 3% of the total healthcare spend in this country. 3% of the total healthcare spend in this country. This ain't the tail that's going to wag the dog, folks. It's just not going to happen. Let me provide another perspective for you about Montana, which I think that you can appreciate. In workers' compensation, Illinois, Pennsylvania, Texas, Florida, New York, California, and Montana make up about 40% of the total workers' compensation premium paid. If you eliminate just one of those states, let's say Montana, if you eliminate Montana, you still have about 40% of the workers' compensation premium paid in this country. Now let me give you a fast rundown on Montana State Fund. We are a part of the state, but we are run as a private carrier. We are an insurance carrier. We're not the regulator. We don't set the medical fee schedules. We pay bills. We provide coverage. Every penny of our expenses are paid not by your taxes, but by the premium dollars that the employers pay. Workers' compensation is the only third-party no-fault coverage in the world. As employers, you guys buy the coverage. The people who work for you get every penny of the benefit. You do not get any of those benefits. It's a no-fault system. If you're on the job and you're hurt, you're paid. That, in its simplest form, that's what it's all about. And as close as we can get to that, the easier, simpler, and less expensive it is.
Excuse me, Mr. Strauss, that's even in the event that the employee is totally liable for the injury? I mean, totally the employee's fault for
Absolutely.
the job, intoxicated, drugged up, whatever? Wow.
Yes, and that's the general rule across the country, not just Montana. Now, there are different laws in different states that say if you're intoxicated and the employer knows about it, some of your benefits may be cut. None of the states that I've worked in, and I've worked in 25 to 30 different states at this point, which have those laws, say your medical benefits are cut. Your wage loss benefits are often cut. That's a tough standard to meet because as an employer, do you want to take your employee who's been a pretty good guy, decent employee, and say, he's drunk? That's a tough call for an employer to make. I've been in those kind of situations with employers where they really don't want to do that. So that standard is very, very rarely applied. So, in fact, I got a funny safety poster today. There's a guy sitting underneath the truck. It's being held up by milk cartons, working on it. And the bottom says, "Safety? We don't need that here." Right? And the question that I got from my friend who sent it is, would workers' compensation cover this injury? Absolutely. We cover stupid. We cover stupid. That's the way the law is written. And I don't have a problem with that. Those are the rules. We all play by those rules. We know what they are. I've got some slides here. This is the Montana law. What I want you to take out of here is wage loss and medical benefits to a worker suffering from work-related injury or disease. Got to be work-related. What I want you to take out of this one is wage loss benefits are not a guarantee of full replacement of wage loss. Montana pays 66 2/3 of the state average weekly wage. State average weekly wage in Montana is under $30,000. Can you afford to live on 2/3? Right. It's tax-free. You're not going to get rich on a workers' compensation claim as a general rule. Here's our public policy. Return a worker to work as soon as possible after the worker has suffered a work-related injury or disease. Those are nice words. I got to tell you, from my perspective, and despite the fact that I work in the insurance industry, despite the fact that I work for a workers' compensation insurance carrier, my perspective is return this person to as full a life capacity as possible after suffering an injury because they went to work. Kay is telling me I've only got 5 minutes, so I'm going to zip through some of this stuff. But I ask you to trust me that the law says we provide reasonable and necessary medical services. So when Kristen asked me access to pain management, reasonable and necessary medical services, that's what the law requires. Treating physicians, under the law, treating physician, dentist, osteopath, chiropractor, PA, ARPN, or APRN, I'm sorry, or somebody, those fields licensed in other states. So here's the goal of the system. Return them to as full a life capacity as possible. We talk about workers' compensation. We provide benefits. We're talking about the economic aspects of people who get hurt. We're not talking about the social aspects. We're not talking about what happens to their families. We're not talking about what happens to their lives, though it's a fair conversation. Workers' compensation is driven by law. If we have a dispute, if Dr. Seacrest and I disagree on appropriate treatment, I'm not a doctor, I can't tell him he can't do that. I will have other doctors who will provide that information to him, share it with him if he disagrees. Ultimately, we go to court. It's not a contract dispute, it's a statutory dispute. Here's what oftentimes happens. Somebody gets hurt. Too often, I know that the physicians and the treating physicians are saying, you know what we've got here is not really a medical issue. The employers are saying, you know what, this isn't mine. This is a medical issue. And what happens right in the middle is that people fall through the crack. And that's where I think we run into most of the questions we've got when we talk about pain in workers' compensation. This is far too often what really happens. Now let me throw another one on you. Okay? Patient comes in, overweight, diabetic, smoker, now has a hurt back from work. There's no mitigation of those issues for workers' compensation. We got it all. We absolutely have it all. The Old Fund, you're familiar with the Old Fund? The Old Fund reports to me. Every week, I sign reserve changes up into the millions. $5 million, $6 million, $7 million, because these people. And in all honesty, I try to keep the perspective that there but by the grace of God go I. These people are lifelong injured. They suffer real pain. I don't for a second doubt. My question to you, the question that we have to answer is, what do we do about providing them the best quality of life that we can? It can't be just putting them on the pain medication treadmill. It can't be. But right now, that's what I'm seeing through the claim files. And you know it when you have somebody who's been on opioids for enough time, their receptors, and please excuse me, I'm not a medical person, the receptors meld or mold or, do something where this is only my first language as well. I'm going to do so much better with the next one, I promise. But the receptors are such that they become immune to the benefits that those drugs can provide. So we increase the dosage. So we change the drugs. I'm paying about 43% of my total drug spend on opioids. That's about $3 million out of $8 million per year. 43% of all the scripts written that I pay for are for opioids. I don't necessarily have a problem with that, but that's a lot of opioids. And what benefit are we providing? Are the questions that we ask. What can we do to help these people live a better life? So access to pain management, it's the primary physician, it's the treating physician. What does a comprehensive pain management plan look like under workers' compensation? On a patient-by-patient basis, you tell me. I don't have a whole lot of options, I have to pay for it. You tell me we've got to go through a detox program, we buy detox programs. I can't tell you how many of them I've signed. You tell me we need to change the regimen, we've got to send them to California, to Washington, to Denver. I send them to California, Washington, and Denver. This is how, unfortunately, we have to do our business. I'd love to do it another way. I'd love, and in fact, I don't know if you've heard of it, but in Montana there's a program called the 60 Summits, which is a new grassroots approach at getting everybody involved in the system. Insurers, because what the heck, we start with me. It's all about me. Insurers, business, labor, injured workers, in addition to labor, medical providers of all stripes, from the crystal healers right through to the orthopedic surgeons and the neurosurgeons, talking to each other on a one-on-one basis. Hasn't borne any fruit yet, but I know personally I've got different relationships with some of the plaintiffs' attorneys that I had before, because we sat down with each other for 2 days and started talking to each other. It's a whole different gig. Whole different gig. And I look forward to helping that program succeed here in Montana. So, Kay, I'm gonna, oh darn. She says you only have another minute of my torture.
You need to lift your mic up again.
Need to lift my mic up. You know, the jokes aren't really all that worth hearing. Except for the jokes. Let me, there are a couple of presentation packages on each table. I'm sorry I didn't bring enough. We will be posting it on the website through Kay. If you'd like it directly from me as well, please feel free to give me your card. I'll be happy to send it to your email. Here's a picture I wanted to leave you with. When we talk about people making money on workers' compensation, this is a study from New Mexico, California, Wisconsin, Washington, and Oregon, which are relatively which represent a reasonable cross-section of employments, large and small states, rural and industrial states. What you see here are the 5 years prior to an injury, then the steep drop-off is an injury time, and then 7 years after an injury, what the wages are like. This weighs heavily on our minds, that when somebody goes on workers' compensation, good things don't happen. despite as much as we try, despite our efforts. And I make fun of myself as a boss because my staff really does care, and they can handle it. We really do care. We do try to do the right thing. Are we perfect? Not even close. We are human. But when we make a mistake, we will try to fix it. But when somebody goes on comp, good things don't happen. We would love to prevent it from happening in the first place. But after it happens, we got to try and do the best we can to get them back to where they were. Real fast, if somebody's been out for 12 weeks, the likelihood of them coming back to their time of injury job is pretty low. Pretty low. Dr. D, I would bet that you and I, having grown up in New York, understand that I'm missing a few words in that sentence. Okay, thank you very much. Ladies and gentlemen, thank you for your testimony.
Okay, thanks a lot. Well, I guess it is getting late, but we've got the panel captured. 20 minutes, so if you guys have questions or would like to address any questions to the panelists, go to one of the microphones. You got one. You got your own. Uh-oh. This can't be good.
Whoops,
Security?
Mr. Strauss, the level, is that individuals that are still on the compensation, the drop?
This picture?
They're still on comp. Okay, so we haven't retrained. I mean, that's
if they return to work, this is their wage level. If they return.
Yeah. You mean they've returned to work and that's still there?
Yes, sir.
Yeah.
Because they can't handle jobs that like what they did before.
They can't.
Yes, very often they can't physically capable of doing the kind of work that they were doing before,
okay,
or emotionally cannot do what they were doing before, for some reason or another. I'm sorry?
Or no one will hire them because they have an injury.
The question is, or no one will hire them because they have an injury. Less so, I think, than in a few years past. Each state has a thing called a second injury fund, which provides coverage for the employer if you hire somebody who is disabled as a worker's comp, as a result of a comp.
It does work in some instances, but I can't tell you how many times the employees tells me, "Oh, my boss told me I got to come back 100%." Now, you tell me how after a lumbar discectomy infusion, they're 100%.
That employer is stupid.
Yes, we know that. And the other stupid employer is the one that tells them, "Well, why don't you just wait and see how you do, and then we'll report it to workers' compensation." Now, what message does that send?
When I get those kind of employers, we charge the heck out of them. We don't have an opportunity. Montana State Fund is the carrier of last resort. Nobody in their right mind would provide workers' compensation coverage for an explosives manufacturer, correct? The law says every employer has to have coverage. We are the fail-safe mechanism. We will provide them coverage. However, the law also allows us to charge what we need to charge that employer. So when I get those kind of employers, and we do track them, they get charged a lot. And hopefully the economic pain is enough for them to realize that they need to change what they're doing.
Now, my next axe to grind is actually with my own colleagues. Workers' compensation is a specialty. Not every physician, you have to work at understanding ergonomics, orthopedics, neurology, gait, and the IME physicians, there ought to be a law that in order to be an IME physician, you have to be an active physician treating workers' compensation injuries. It's not a kick into retirement. This is between you and me.
As long as it's just you and me. Well, you know, we have a member of the legislature here. One of the problems that I will have with that kind of thing, however, is in a state like Montana where we don't have a plethora of physicians, At some point, we're going to run out of IME physicians because frankly, you've got other work that needs to be done. And workers' compensation, I'll be the first to tell you, workers' compensation is a pain. I have dreams, and if you don't have your dreams, you have nothing. I have dreams of changing that for you. Those dreams will turn into plans. I can't tell you when, but give me time.
I'm from Wisconsin.
The state with the first workers' compensation law that passed constitutional muster.
Indeed. Indeed.
And you don't know nothing about cheddar cheese, buddy. My family is also from northern New York, cheese country, real cheese country. We know sharp cheddar cheese bites back. You gave me the microphone. I am your fault.
Yeah, but you had to steal some Brett Favre.
Take him back. Take him back.
Never seen someone burn through that much goodwill in 1 week.
It's true.
Where was I? All right. We have lots of physicians, but we have a lot of IME docs who blow into town like Gary Cooper in High Noon, you know. And they set up in a hotel, and they see a dozen patients in 8 hours. They examine each one for 5 minutes. And they pocket their 24 grand or whatever, they blow out of town to go on to the next. Now, I am a treating physician, and I've done some IME work, but they don't want anything to do with me anymore. I don't get much IME business because I always say what I think. And I always tell what I think is the truth. And I really do think some changes need to be made in that link because, sure, there are going to be areas and times where disputes arise about what is appropriate. But who are you going to get to be your arbiter? And we've seen time and again people who have a reputation of saying whatever the person who pays them wants them to say. And I think that is something that we need to be working pretty hard on. I don't know the solutions either, but something worth working on.
I'd like to talk to you afterwards if I could. We'll start getting some information about you and your work. Let me also tell you one of the dirty little secrets about workers' compensation in Montana. We can get second opinions, we can get IMEs. If the treating physician disagrees with it, it really doesn't matter. It really doesn't matter. The best that we can do is hope to create a dispute so that we can create a settlement. So that we're not in agreement with the injured worker and ourselves in the first place. We can come to terms where we can part and divorce ourselves from each other. And they can live their lives happier for not having to fight with us. And hopefully have a better life for it. So, I don't know if we use some of those blow into town docs. I suspect you'll tell me.
I just wanted to say that you are welcome to ask questions of any of the panelists now.
Please.
I have another workman's comp question. Before you go.
I'm sorry we're closed. Thank you so much for your
I've been wanting to talk to you for a while. Over the last month or so, have there been rules and regulations change in workman's comp that we weren't notified of by any chance? Regarding day-to-day providing care for workman comp injuries?
Not that I know. The question was, have there been rules or regulations changed regarding providing day-to-day care? You're leading to something that I don't know.
Well, I am a nurse practitioner and I work in an urgent care clinic and I'm the main provider there. So we have a physician that works 1 day a week and we have nurse practitioners the rest of the time. And this is in Hamilton. And our job is to see whoever walks in, well, all the local nursing homes and so, feed mills, et cetera, whenever anybody gets hurt, not seriously injured, they send them to our walk-in clinic. And we provide care for them, and then we give them out for work, to be off 2 or 3 days or 4 days, and have an x-ray, or fix them up, or treat their burn, or whatever, Lumbar or just minor back strains from the well, not necessarily minor, but back strains from the nursing home, etc. So we provide care. When you say, well, in 2 or 3 days, we want to recheck you, or 4 or 5 days, depending how bad they're feeling. And we want to see you back. And if you're doing really well, then we think you can go back to work. And we agree with you, then we'll send you, let you know from your employer, you can go back to work. All of a sudden, about 3 weeks ago, we get these letters from workman's comp saying, well, how many pounds can this patient lift, and are they disabled, and blah, 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 blah. And we weren't, we tried to find out where they came from, and I mean, they were the first time in years I've ever seen these, and I don't know where they came from, and they said only 3 or 4 physicians in the community are able to sign these forms for you. Well, 2 of those physicians don't even bill workman's compensation, period, for any injury as of recently, according to a patient who goes there. And so we have no one essentially in the community that's willing to sign these forms because they don't have time to see their own patients, much somebody else's back pain. They just don't want to do that. So it's an enigma for me to figure out what to do with these people, how to get paperwork done. And I guess wonder why I'm not allowed to send somebody to physical therapy to do that type of evaluation, read the therapist report, and then decide whether that patient's ready to go back to work or not.
My response is, first, you can do that. If you're the treating physician, and nurse practitioners are permitted to be treating physicians in the state under the state law, you can send them to physical therapy and say, fill out this form, see what they're capable of, and let me know. And I believe, and I could be wrong, that you can sign that form. That form is not particularly new. We've been using it about 5 years. I got here 6 years ago.
I do remember seeing it about 5 years ago, but I haven't seen it since. And all of a sudden, we called the claim, adjuster and said, well, who's supposed to fill this out? He said, only these special physicians, certain physicians are allowed to fill that out. But like you said, they're not willing to do it. So we're a pretty paddle. So,
well, let's get together on your specific situation. But
okay. Thank you.
I can't tell you what other carriers will or won't do. I can tell you what our standards are. We're a carrier. We have a work capacity form. We've been using it. I can also tell you that the state as an employer, forget about the state fund, the state as an employer is getting into this business big time. And they will want to communicate with you directly. They've got their own form. And whether you sign that form, whether you use that form or not, from my perspective, more information to the employer and to the carrier, better. So it's important to me that you don't get deluged with stuff you don't necessarily need to deal with. I do need that kind of information. We'll supply you a whole list of forms, a whole package of forms, rather. When you first see that person, fill it out, sign it, send it in with your notes, and you're done. So.